Average Joe PT. This channel is all about physical therapy, fitness, education, and a little bit of fun. Now, today we're going to try and sift down all the mumbo jumbo that the doctors throw out to you and give it to you Average Joe style. All right. So today we're going to talk about hip replacements. Why? It's only old people that get hip replacements, right? Not so anymore. Probably over the last, let's say 5 to 8 years, somewhere around in there, hip replacements and knee replacements made a giant quantum leap. And when it comes to the type of materials that they can use nowadays to make the replacements last a lot longer than they did. When I first started out a long time ago, all right, hip and knee replacements, they were only given to patients when they were in their 60s because the replacements were only lasting about 10 years and they were breaking down, and they would have to do what they call multiple revisions. They'd have to take out the old hardware and put in new hardware again. That's changed. Now you got people in their late 40s and on up getting replacements. So today we're going to talk about the two types of hip replacements. What are their positives? What are their negatives? What are the precautions? What can I expect post-op and pre-op when it comes to the hip? When is it okay to get a hip replacement? Obviously, your surgeon is going to be the one, but you might actually see a physical therapist first, hoping that they could maybe keep you from getting needing to get a replacement. And this is going to talk about hip replacements. So hold back, get some popcorn, get some soda, and here we go. All right, folks, so we're back here. And so I got handy dandy Mr. or Mrs. Spine here right now. And so we're looking at the front of the hips, or what we call the pelvis. All right, so we're going to turn you to the side and actually talk about what people really think about is the hip, is actually the ball and socket. All right, so you have the socket right here, and that's where obviously your ball goes into. So we're going to just pretend this is our little femur and the head, and so it fits right inside there. See how you get a nice contrast between what your hip would be and then where the ball would fit in, obviously, and then the rest of this would make up your leg. And so they go ahead and they're going to put a cap on this a cup on this to replace the socket part. And then what they do is they actually cut off the neck, all right, the ball. They cut down through the neck, and then they'll go ahead and drill down in, all right, because the new piece is going to have a head on it, all right. It's going to have that ball, and it's going to have the neck on it that comes down into the shaft like this, and then obviously it goes into your new socket. And so now there's two different approaches like I talked to earlier. All right, there is what they call a posterior approach or posterior lateral approach, where if they come in from the back side, okay, they'll come down through surgically and kind of cut that open. They will pull back and peel. They don't try and cut through the muscles. They kind of splice and pull the fibers apart. All right, they'll come all the way down. Like I said, they'll cut that head, that ball, down to the neck. All right, and then they'll go ahead and they'll dislocate first, and then they'll go ahead and do that. And then obviously, like I said, they'll put the new piece in, put it back, sew it all back up. All right. And so what the biggest thing is what happens with people is you have this muscle that sits on this side here, all right, called the gluteus medius. And that glute muscle there, that glute medius muscle, is the muscle that really keeps your hips, when you're walking, from kind of dropping down. And also it allows your leg to go out to the side. And so that muscle is going to be really weak, and you rely a lot on it. You don't realize it after surgery. All right, the other approach is called the anterior approach. It's been going around for about 10 years or so. So you have to really look into the surgeon that you're talking with to see which approach they do. Now, certain physicians only do this posterior lateral approach. That was the gold standard, so to speak, and that's what they were using for years. And now they're doing a lot from the front. So what they do is they use a machine to kind of distract it out from the front. Okay, they pull it out, and then they go ahead and replace from this part. So you get away from cutting through all the muscles on the back side here. All right, and so the weakness right after surgery is going to be along the back side here, and so they're not going to allow you to what we call past 90. So they don't want you to pass your hips past 90 degrees, whether you go this direction, all right, or whether you go this direction. All right. They also, the other precaution for that back approach is they don't want you crossing your leg. So crossing your leg, and they don't want you turning your foot inwards. All right. And the reason for that is because when you do those 3 directions, the ball actually starts to go backwards. Okay. And so if the ball's going backwards and all the tissue just got cut into, you could cause a dislocation. So that's why they have those restrictions, and they have them for most people somewhere between 2 and 3 months. All right. Once that's done, obviously they'll go ahead and you can discontinue that precaution. Now the anterior approach, when they come in from the front, they pull it out this way. There's really only one restriction. The restriction is not allowing your leg to go back. All right, because they did all the work in the front of your body. All right, and so if you think about it, if your leg goes back, the head of the femur goes forwards, and you could dislocate forwards. But that's the only restriction. Excuse me. Now most people aren't going to kick their leg way back. Trust me, you have this type of surgery, you're hurting enough, you're not going to be doing that. But there are no limitations when it comes to trying to tie your shoes. All right, trying to put on a pair of pants or a pair of socks when you have this anterior approach. The backside approach, you have all those restrictions. All right, you're gonna need a device to put on your sock or put on your shoe or put on your pants when you have this old posterior lateral approach done. All right, so that would be very mindful of you to really talk to the surgeon in which approach is most appropriate for you. Well, like I said, there's only one restriction when you go from the anterior front approach versus the posterior lateral approach. So that describing those two. All right, let's go ahead. We're going to put handy dandy Mrs. Spine to the side here. All right, what we're going to do now is just go over some exercises, all right, that you can do at home post-operatively, all right, that you should be careful with. All right, they should give you some exercises to go home with. These should be those ones that you're going home with. They might give you some more, but they should at least give you these exercises. So let's go ahead and talk about that for a few minutes. Show you those when we come back. Here we go. All right, there's one more little tidbit I forgot about, and I want to talk about it now. And so when you have the surgery and you're just get out of the operation, get in recovery, and you're up in the room, your physical therapist will usually see you that day, okay? Or they will see you the next day. They're not going to have you in the hospital no more than 3 days. Now, is that not because they want to kick you out? It's the fact that the longer that you're in the hospital, the more likelihood that you can get something else, either get sick from somebody else. When you go to the hospital, you're not going to the hospital because you're healthy. You go in the hospital because you're sick. And so it's very easy to catch something else if you're there longer. So that's one reason why they want you out in 3 days. Within 3 days, and when the therapist gets you up, the reason why they want to get you up as soon as possible is because you want to reduce the risk of blood clots. Now they're going to give you all types of medications and stockings, compression stockings to reduce it. But the best reduction of blood clots is getting you up and walking you on that limb. Obviously with a device, probably a rolling walker. All right. So that's what they will expect you to do the first day. Now, are you going to go home? You might go home. Either that, you're going to go to rehab. If you have a lot of what we call comorbidities, you got diabetes, you got blood pressure, maybe you've had a stroke or something else going on, and you're just not strong enough to go home, they might send you to what's called short-term rehab for maybe a couple weeks, and then send you home, and then obviously send you out to an outpatient physical therapist like myself. All right, which they will kind of progress you from the standpoint of either the home care therapist if they go and see you, or from the rehab therapist. So that's some things that they also might do for you out of surgery. The other thing is the weight bearing status, which means is how much weight can they put through that leg. Sometimes the physicians will make you partial weight bearing, all right, versus weight bearing is tolerated or full weight bearing. Depending on who the surgeon is, they have the acronyms of whatever they want to call it that day. But those are the gist. It's usually either weight bearing as you can put through your leg, or they might make you restricted partial weight bearing. It might be 50% of your body weight, 25% of your body weight. Anyways, there could be some limitations, which then that might make you take a little bit longer to recover. Expect to have your staples out in 2 weeks. You'll get out of the hospital. Within 2 weeks, you'll get a follow-up appointment with your surgeon. They'll look at you. They'll do a follow-up x-ray. They'll take your stitches out, staples or sutures, however you want to call them. This is the average Joe. We're going to keep it simple. I'm all about keeping it basic here. All right, and then you'll go to outpatient after that. All right, so let's go ahead. Let me show you those exercises that they should give you for home. Here we go. All right, folks, we're back. And so let me show you a few of those exercises you should be doing. All right, first thing, before the exercises, you're probably going to want to be in a recliner chair and ice baby. All right, you want to put as much ice as you can tolerate. Like I always say, 15 to 20 minutes. Just be careful that you don't burn yourself. That'll reduce the swelling and inflammation and some of the pain. All right. One thing I want you to do is, obviously, you're going to do these exercises. Excuse me. You're going to do these exercises in the bed. You're not going to. Don't even think about that. I mean, that's not even in your thought pattern, being on the floor after a hip replacement. All right. But what you're going to do, right? One of the exercises you're going to do is you're just going to have your legs out as straight as you can tolerate them. Kind of have them out nice and stretched, and just kind of tighten your butt muscles up. Hold it for about 3 seconds and then relax. 3 to 5 seconds, hold, squeeze those butt cheeks together and then relax. You're gonna do about 15 or 20 of those. The next one I want you to do is just gonna slide that leg up, what we call a heel slide, and slide it back down. Slide the other one up and slide it on down. That's another nice exercise to do just to get the hip moving a little bit. Now that hip, when that moves, that might just move a little bit and then come back down. Now you're never going to break the precaution if we're talking about that 90-degree angle when you're down flat like this. You just slide it up and slide it down. That's a nice exercise to do at home. If you can, slide them both up just a little bit with your feet together, and then just gently open and close your knees, what we call the clamshells. Just nice and easy. Open and close, maybe 15 or 20 of those exercises when you get home. All right, after probably 2 or 3, that's it. Those are 3 exercises with ice. Trust me, just to keep the thing moving, get up on it, walk it with a rolling walker, as long as you're not a fall hazard, just to keep things going. Would not recommend you do anything like this. All right, even with help, because you can get this hip flexor in the front. This big muscle can get inflamed and irritated, all right, because all these muscles around this area have all been caught, all right, and been pulled and stretched that have never been stretched before after having surgery. So these muscles are really weak. These muscles are going to over-dominate. You're going to get the darn things inflamed, and then you're going to be in a whole mess of trouble, all right? All right, stay away from stuff like this. In 2 or 3 weeks, yes, you can progress to stuff like this. That first week or two when you still got that staples in and we're just icing, those first 3 exercises are the safest to do to keep things going, keep the range of motion going so it doesn't get too stiff on you. Some gentle active motion that won't break any of the precautions that you have. And then obviously ice it. So those are the ones I would have you do post-operatively. Now when you're out to the therapist, they're going to probably show you some of these, all right, once you've had that. And you'll probably go into something simple like a bridge, all right? Hold for a second and down. Really get those glutes up. When you're at about, 2-3 weeks into it, they'll give you stuff like that. Now, this all depends if they make you weight bearing as tolerated. That last exercise. If they don't make you weight bearing as tolerated, for those first 3 exercises are okay to do. So those first 3, whether you've had the back approach, the front approach, first day after surgery or not, it's not going to break any precautions from either one of those. All right? The heel slide won't do that. You'll be fine. The butt squeezes or the glute sets, you'll be fine with. And also the clamshells are just gently open and close. Now you might be down like this. You're not going to be able to come up that far because you'll be hurting too much. But just gently open and closing. You're not breaking any of those 3 precautions from any of those. So those are the exercises and the tips I would give for you. Now let's go ahead and finish up this episode. If you have any comments, all right, please down below. All right. Ring the bell, subscribe button too. Love to push it. I'm going to keep bringing you content, some good information that you can use, hopefully make you smile a little bit, hopefully make you think a little bit, bringing that information down to the level that everybody understands. All right. So like I always say, look up and keep smiling.